Hey everyone, it's Dr. Steph. I'm an assistant professor at the University of Toronto, Department of Family Medicine, and today I'm going to be doing a recording of the lecture I gave to the McMaster Family Medicine Residents. This is a 2024 update to the Family Medicine Billing lecture that I uploaded to YouTube in 2021 as billing codes and family practice in Ontario is constantly changing. And if you find my lectures helpful, please like and subscribe to be notified of future lecture recordings. So today's lecture is going to be in two parts, and this first part is for first-year residents, but feel free to share my lecture with anyone who is from another province or country coming to Ontario to be a family doctor. We will be covering these topics for today with a focus on billing for family doctors practicing in the fee-for-service or the Family Health Group or FIG model. If you will be joining a family health organization or FO model, there is another video for that, which I've linked above and in the description below. So to talk a bit about my own practice, I do addiction medicine and family medicine. I have a roster of about 850 patients, and I work 2 full days of family practice as the FO lead. While on the other days, I do addictions, inpatient and outpatient clinic. I develop and give lectures, I do research administration, and on the weekends, I record my lectures so that learners across Canada can access them for free. I supervise psychiatry and family medicine residents and clerks 5 days a week, so if you want to do an elective, feel free to reach out. I don't have any conflicts of interest to disclose. So before I start the lecture, I want to always see who is in the audience today and get a baseline understanding of what everyone wants to know. So the first question I usually ask is, for all of these residents, how much have preceptors spoken to you about how they bill and how they get paid in their work setting? And for most residents that I've taught at McMaster, Queen's, and U of T, their preceptors have talked to them about billing, which has actually improved from previous data. So this is good because the best way to learn billing is through longitudinal practice, and sometimes reviewing this lecture a few times helps as well. The second question I usually ask is about comfort levels when it comes to asking preceptors about billing. And back in 2021, when I started teaching this stuff, a lot of residents were not as comfortable, but now, compared to before, more residents are feeling comfortable having the conversation with preceptors about billings, but there's still room for improvement. People who selected in the other category were comfortable asking about how to bill, but not necessarily how much their preceptors make. And this is a new question that I started asking students this year when I teach. And because I develop resources on practice management, I wanted to know what kind of topics audience members wanted to see more of to help them transition to practice. And this was the results. So most residents wanted to learn about practice efficiency and what to be careful about when signing a job contract. So for those of you who selected the contract option, there are actually lectures and interviews on this topic that I'll link above and in the description below. And if there are any other topics that I haven't included that you feel you wished you knew, please post them in the comments below. Finally, I always ask my audience what they think family doctors make per hour after overhead. And most residents said it was $100 to $150. There's a reason for this exercise, but I'll cover that in the later slides. So before you need to know anything about billing, you have to know what you can and cannot bill OHIP for. So the first thing you need to know is any time you spend in the patient's presence, any travel to the patient's homes or hospital to do call, and the cost of some supplies are things you can bill OHIP for. But there are actually a lot of things you can't bill OHIP for, and namely, you can't bill OHIP for the time you spend billing. So if it takes you a really long time to do your billing or you're spending a lot of time fixing rejections and so on, that might not necessarily be good time spent because you're not actually getting paid for that time. And all of this unpaid work do come at a cost. So for example, when a lot of residents say, oh, I can't wait to graduate and make staff physician income, I can see why they say that, because when they look at the average income of a family doctor in Ontario, it's around $240,000, and that actually is a pretty good income. But when you break it down in terms of the hour, assuming you work 52 weeks a year, assuming that you would have about $1,000 a day of billings, and if you're a locum, that's approximate typical locum daily rate. And you take out taxes from that as well. So you take out $49 per hour in taxes. That gives you an after-tax hourly value of your time of $76 per hour. But remember how I said there's also a lot of cost of unpaid work that you spend time on too, right? So you might spend 2 to 3 hours after work to chart, to bill, and to do administrative stuff too. And that also should be factored in as a cost, right? So doctors might have a high income, but they also work many hours, and much of those hours are doing unpaid work as well. So that actually comes out to be about $42 per hour after tax. And I actually haven't included overhead deduction in this as well, because overhead varies depending on geographic region. So the reason why I did this exercise is to show residents that there is meaning to the phrase, live like a resident for the 2 to 5 years after residency, or else you'll be living like a resident for the rest of your life. So it's important to not let that lifestyle inflation get to you, and to focus in your early years on living frugally, paying off your debt, and developing a good understanding of your cash flow and future expenses. And remember to not fall for the lifestyle inflation so quickly in your career. So let's get to the 3 main billing habits you should start developing if you're in residency. So the first tip is ask your preceptors if there's anything you need me to include in your note for billing purposes. And so the reason why you should ask this, especially if you have a preceptor who's doesn't really want to talk to you about billing, or is not comfortable, or you're not comfortable asking them directly about their billings. Think about it this way. A lot of staff physicians would prefer it if their resident makes their life easier, including making it easier for them to bill. And so if you're not that comfortable asking them directly, this is an indirect way to do it. Sometimes preceptors will ask their residents, can you make sure to collect the patient stickers of the patient you've seen for me? And the reason they do that is because they need their OHIP number in order to bill. So take the initiative to do that for your staff physician. Sometimes staff physicians will ask you to write down the start and end times that you spend with the patient. And the reason for that is because there are some billing codes that are time-based. So your staff will only get paid if you spend at least 20 minutes with the patient. You also want to get in the habit of signing your notes like this. So most residents sign their note kind of like the first example. But what I suggest is you start signing your note like this. You want to write your name that you reviewed with your staff's name. You want to write the time you spent with the patient, and think about what billing codes you might bill for that patient. So the reason why I've included this, and I suggest this if you're a resident, is because you want to get used to putting the time spent so that it can help you improve your own office efficiency. And if you ever get audited for whatever reason for a time-based billing code, at least having the time in the note covers you and justifies why you billed the way you did. I also recommend my residents to try to guess what billing codes they would use, because if they get it wrong, at least it's a way for them to learn. The preceptors will sometimes tell you, by the way, I noticed you billed this, but it actually should be that. And that's all good, because if you get it right, then it makes your preceptor make it easier for them to bill as well. So for example, in this particular case, I put the billing code, primary mental health care, and then I also included a diagnostic code for the diagnosis. So this makes your staff's life easier and also helps you learn billing indirectly as well. Final tip, you want to start compiling templates. So I actually started compiling templates since I was a resident, and whenever we finished clinic at 4:30, I was usually out of there. And a lot of residents who worked with me stayed until 7 p.m. charting. And they thought I had a chill schedule, but the truth was I actually used a lot of templates to reduce my charting time. So I've actually included my templates in the description as a resource, and this is something I've been building up since I was a resident. If you have a certain template and you want to contribute to my Google Doc, feel free to reach out to me, and then I can even add it in so it'll benefit other people as well. And templates are especially good if you have redundant management plans, like things that are the same for every patient, such as maybe MSE and UTI management. And the other thing about templates is that it's good from a medical legal perspective, because for my templates, I usually have red flags to watch out for. And so by putting that template in there, it reminds me to talk to patients about those red flags. So now let's talk about the main billing resources. So I always tell people it's more important to know where to look than to know the answers. So if you were to take anything away from my lectures, it's probably these next couple of slides, because that's all the resources you really need to learn how to bill. So, there's so much to learn in family medicine. There's a lot of topics to memorize. So often when it comes to something we don't know about, you always know where to look rather than know the answers, right? You might go to UpToDate if you're not sure about something. So what should be in your billing toolkit? The first resource is the SGFP Common Billing Codes. There actually is a 2023 version, but I don't like the way that it's organized as much as I like the 2022 version. So I'll link this in the description as a resource as well. And I would bookmark this on your clinic computer so that after you see every patient, you can pull this up and bill for that patient right after. The second resource is the Schedule of Benefits. This is kind of like the master guide. It's like a 400-page PDF document. I do not recommend you reading the whole thing. There's better things you can do with your time, but this is only useful if you look on the SGFP document and you're not really sure like when to bill something and you want more information, you can consult this resource next as well. The third resource is that throughout the years I've been teaching practice management, I've kind of collected a bunch of my lecture recordings and I've uploaded them to YouTube. So the first two lectures are the older 2021 version of this lecture that I'm giving today. But they're still there as a refresher. And then I've made several other lectures about how to read your remittance advice, the income stabilization program, and FOE specific billing based on popular demand by my students. So you can definitely check this out on your own time. And especially if you're working in a FOE, the billing is kind of different as well. And so you might want to watch those particular lectures before you start working there. Number 4, the OMA billing guide. So the Ontario Medical Association has a set of modules, and they sometimes run these billing talks as well. So if you have an OMA account, definitely log in and look it up, because these are other resources you can reference to. And finally, the first 5 years in family practice. There's one in Canada, one in Ontario, and this is a great guide because even if you're not in first 5 years, sometimes I see people on there who are like 10 years out or longer, and these are a lot of good mentors that you can reference. So whether you're not sure about how to bill for something, whether you're not sure about an ethical question or a clinical question, like who do I refer, this is a good resource to use for that. And between all of those 5 resources, you should be able to do like 90% of all of your billing. Finally, don't discount that, you might be working in a team and you might have a billing manager or other clinic physicians in that team for you to ask as well. So let's talk about your EMR and how to understand your EMR. So when I first graduated from residency, there were so many different EMR systems to get used to. And whenever you're locuming, you might have to get used to every EMR system every couple of months. So I've kind of listed them out here as well. The other thing I also found surprising was that when I started working in a hospital, I actually did not realize that hospital EMRs don't have billing software already built into it. So I had to get my own. And there are a number of private billing softwares out there. I'm not going to say or promote any particular one. These were just ones that were recommended by other physicians that I've worked with. However, what I would suggest is you can do the free trial for all of these billing softwares, and then in the end, pick one that you particularly like. So let's also talk about the billing components on an EMR. So when you go and start billing on your EMR, there'll be several different subtitles, and you input the billing codes and the different information in there. So the first thing that you'll see is an area for you to have the patient's OHIP card number. You'll see an area for the billing code, and sometimes the billing code will have something called a suffix. So for example, if you might have something like K088A, and A means that you were the consultant in that particular case versus like the surgical assist. Then you have something called a diagnostic code, and this is particularly important for bonuses because if you have a certain number of diagnoses in your roster, it will give you a bonus at the end of the fiscal year. More on that in a later slide. Finally, you have a quantity, and the quantity is where you have time-based billing codes, and we can touch on that later, but with certain billing codes, you can bill 1 unit or 2 units and so on and so forth. The submitted section tells you whether you submitted it or not, and you always want to remember to submit your billings by the monthly deadline to get paid next month. The main thing to remember is you can't bill until you have a billing number. So in this lecture that I gave a while ago, I did talk about my experience with getting a billing number, and sometimes it can be pretty stressful because you need your CPSO number first before getting your billing number. I also touch on a bunch of other stuff like how to prepare for graduation, job search, and so on. So I'll link this as a resource in the description below. Okay, so now let's talk about the high yield billing codes. And these are the most commonly used billing codes. And I've updated this lecture for the virtual care changes. So remember the golden rules of billing. Number 1, you always want to be honest. You always want to make sure your documentation is comprehensive because it is the only proof that you have for why you billed the way you did. And if you're not sure, you can always email economics@oma.org or talk to any of the people on the first 5 years, talk to your colleagues for advice. So the first thing that you want to know about your billing codes is if you have the SGFP document on another screen in front of you or on a page in front of you, you can reference it here. So common fee codes include A001s, which is like anything quick. For example, doing a refill, doing a sick note, simple rash, things like that. A007 are things like the most office visits. This is probably the most common billing code as a family doctor. You do a history, you do a physical. A003 is a bit more detailed. So it's kind of like if you're doing your medical school history and physical, you're examining 2 systems. You can bill this one time per patient per year unless they come in with a different issue. So for example, if a patient comes in with chest pain, you might examine 2 systems. You might examine cardiac system, respiratory system, maybe even GI system as well. And you're doing a very comprehensive assessment. So you can bill A003 for that. And then the K013 is a counseling code. And this is if you see someone for more than 20 minutes, would be a good idea to include the timestamp. And this is when you provide any education that may not necessarily be mental health counseling at a pre-booked visit. So for example, talking about obesity or cholesterol, for instance. Now, with the advent of virtual care, there are also additional codes that you bill if you see someone by phone or by video. So a K301 is a tracking code. It doesn't pay as anything, but it helps the computer system recognize which codes you bill were because you saw someone by phone. And a K300 is a tracking code for if you saw someone by video. And the K301 pays at 85% of the billing amount, and a K300 pays at 100% of the billing amount. And this is only if you have an existing or ongoing relationship with the patient, otherwise known as EOPPR. So more on that in a later slide. There are also other things I want to point out on your SGFP document, there are a lot of visual symbols that I want to draw your attention to. So for example, whenever you see a little N in red, that stands for FIN. And so those are different fee codes that are out of basket if you work in a family health network model. If you see a little O, those are the visual cues that these are the out of basket codes for the family health organization model. And out-of-basket codes are paid at the full amount rather than a small shadow of that amount. So this might not be relevant for you if you're working in a fee-for-service or a FIG model, but if you want a refresher and more information on this, reference that faux billing lecture I talk about. The other symbols I want to point your attention to is this little caret symbol, which just is a visual cue for you to add a tray fee to that particular billing code. And it gives you a little extra to fund your office expenses, supplies. And then there's a little plus sign, and that just is a visual cue for you to add G700, which is the basic fee for those codes if it's the sole reason for the visit. Okay, so virtual care codes. Let's go into this a little bit more detail. So there are 2 sets of virtual care codes. First is if you do limited virtual care. So for example, if you're working in a walk-in clinic, and you don't have any relation with the patient, it's like the first time you've ever seen the patient, you might bill something like an A101 or an A102, whether you see them by phone or by video. And you don't need to add K301 or K300 to this. It's automatically assumed that you're doing virtually. Doesn't matter how long you spend with a patient or how less time you spend with a patient, you get paid the same regardless. Now, if you work in any of these particular models and you have rostered patients, with some exceptions, you have now existing and ongoing patient-physician relationship, or EOPPR. So all of the key terms are in bold and in blue. And this is an important term because what this means is that you have either seen this patient in person at least once in the last 2 years, or they are rostered to you and enrolled to you or another doctor in your group. And how you know that they're enrolled is because that patient has signed the patient enrollment and consent to release personal health information form, which looks like this. You also, when you're rostering patients, you would bill like a Q200, which is another tracking code. It's paid at nothing, but it attaches or tells the system to attach that patient to you now. The other exception, if that patient is not rostered to you, is if you have a focused practice. So for example, I do addictions. So if I did a video consult with a patient in the last 2 years, I have that EOPPR with the patient, and so I'm able to get that use those Ks301, K300 tracking codes with my billing codes as well. So how do you maintain EOPPR? So if you work in a family practice, as long as that patient is rostered to you or you've seen them in person, at least in the 24 months, you have that relationship and you can bill that full billing code instead of the A101, A102. You always want to make sure your office manager checks a patient is rostered to you regularly, because we've also noticed sometimes walk-in clinics who may not actually have EOPPR with a patient roster the patient anyways. So just make sure you always check that. If you're in a focused practice, just make sure that you see them by video at least every 2 months, and if you every 24 months, and if you haven't, you can always get a re-referral from their family physician to continue care for the same issue. There are certain codes that qualify for virtual visits, and I've listed them all out here. So you want to remember to use this as a reference, just because the K codes, K301, K300, may not necessarily be allowed to be billed for every single billing code, only certain ones that are listed on the screen. And the other thing to remember is that if you call a patient and then you see them in person later that day, you only will get paid for the in-person visit, not for the phone call. So use this as a reference, especially if you do a lot of virtual care. And this is another reference that you can use if you want to make sure that the online system you're using for virtual care actually is a verified vendor, verified provider for virtual visit from a confidentiality perspective. So let's now dive into the mental health codes. Mental health codes are all listed here on the screen, and the K005 is for, you can bill that for any mental health concern more than 20 minutes. And it can be combined with an A007 if the patient happens to have a medical concern as well, but just remember to bill it with a different diagnostic code. You always want to remember to write the start and end time, because for the first unit, it's 20 minutes. But the second unit is not 40 minutes, it's 46 minutes, and so on. So you always want to make sure that your timestamp justifies the billing. The second set of codes you should know about is screening and preventative care codes. And I've listed the most common preventative care codes here. So anytime you do an annual checkup, you can build these codes, and they can be combined with vaccines, vaccine codes, pap smear codes, as well as FIT billing codes too. The other thing I want to point out is the diabetic management code, which is also commonly billed, K030. And this is for when you do diabetes counseling and physical exam. You can bill these up to 4 times a year. And if you're in an enrollment model, like for example, FOFIG, etc., if you've billed more than 3 of the K030 codes in the past, you can add on a Q040. Finally, whenever you do these tests like FIT, some of the forms will have a little box on the side that is a memory trigger, visual trigger, for you to add on a Q150. And if you're in an enrollment model as well, there are certain preventative care codes, which I'll talk on in the future slides, but those might be obsolete soon. So the next thing to know about is vaccination codes. So these codes can be combined with any visit code. And there's now COVID vaccine codes as well, which I've also listed on the screen too. And there are certain differences between whether you're in a FO or in a FIG. So just something to keep in mind as well. If they're only here for the vaccine by itself, you can bill a G700 plus that vaccine code. Finally, the procedure codes are something else you should know about as well. And you always remember to recall that visual trigger to bill the tray fees, because that can significantly help cover the cost of office supplies. The other commonly billed office procedure codes are the pap smear codes. So if you see someone for a pap smear, you can bill the G365 along with the tray fee as well. If you have a nurse practitioner or RNs in your clinic, remember your overhead actually covers their pay, and you can delegate a lot of the work to them, including a lot of these laboratory items. So they can provide a lot of these services for you as well. The next section on the SGFP document are the OB/GYN codes. And so some things to remember are, first, the P004 is for your routine visit, and some doctors might bill this at their initial visit. Some doctors might choose to bill a P003 at their initial visit instead, and this is when a patient comes to you, they're pregnant, do a full physical exam, and sometimes you'll also do that antenatal preventative care form that has all these checkboxes on it. So the P005 covers your time for filling out that antenatal form. So if they deliver and you see them after birth, you can bill this P008, which is the office code. And then the other thing I also wanted to point out is this document might have some typos as well. So in my slides, I'll also point out all the typos, including in this section where it shouldn't be 5 a.m., it should be 5 p.m. to 12. And these are just some bonuses that you can bill for working evenings and late hours, for instance. So what you should remember is you can't combine a 3 and a 4, but you can combine a 3 and a 5 or a 4 and a 5. And finally, just to draw your attention to some of these items here, like the pregnancy test, all of those things you can delegate for your nurse to do, but you can bill for that as well. And there's also the other section about sexually transmitted disease, which if you counsel a patient about their STI and maybe you treat them for it, there is a K028 code, which covers that 20-minute of counseling with STI. On the other part of the first page are the smoking cessation codes. And so this is a code that you should know about, especially if you are seeing a patient for the first time for the meet and greet and you ask them about smoking cessation. So you can bill a E079. I don't know why, but for some reason this code can't be combined with the diabetes visit. The other code that you can think about billing if you call a patient back for a specific visit to discuss quitting smoking or anything about smoking is the K039, and this you can bill twice in a year. Unfortunately, I don't think you can combine this code with another K code. The other thing to note is that you can combine this with a Q code, so Q042, if you have a rostered patient practice. So what is the minimum criteria that counts as smoking history? As long as you've asked them these 3 questions on the screen, that allows you to bill that E079. So for the diagnostic codes, you don't actually need to memorize all of these. A lot of the times when you have an EMR system, when you type in the diagnosis, they can auto-populate the specific number to it. So use this just as a reference. So now let's move on to the practice cases. And this is probably the most valuable part of the presentation because it allows you to practice how to bill and learn by practice. So what I would suggest is that you have your SGFP document in a screen or another page in front of you. And as we go through this, pause before the answers show up on the lecture. So the first case is, what do you bill for an assessment of a 32-year-old male with upper respiratory infection who requires a B12 shot as well? This is a good time to pause the video and look up which billing code you would bill as if this was a real clinic. Write that down, and the answer is B. So the reason why is because the 𝗧007 covers that time you spent doing the talking to the patient about the upper respiratory infection, and the G372 covers that injection with visit. Okay, case number 2. So what do you bill for a complete assessment of an 85-year-old with chest pain, and also you do a urine dip as well? So pause the video, look up, think about what the answer is, write it down, and the answer is A. So remember what I said about conditions that might have a very extensive history. Maybe you do examination of more than 2 systems. That's for the 𝗧003. And it says with diagnosis other than 917, 917 is referring to the preventative health visit. So even though when you're doing an annual physical, you're doing a pretty comprehensive history and physical, it has a separate billing code for that as well. And the G010, that's just your urinalysis code. Case number 3, what do you bill for a 40-minute appointment with an anxious patient who also wanted a pap smear? Pause the video, write down your answer, and the answer is C. So the reason why is that the K005 is your mental health counseling code. And unfortunately, since you only spent 40 minutes, you would just bill 1 unit of that. And then you also did a pap smear. So you want to bill the G365 for the pap smear and E430 for the pap smear tray fee. Okay, case number 4. What do you bill for a medication refill where you discuss the prescription over the phone? Pause the video and write down your answer. And the answer is C or D. And this all depends on how long and how detailed you really talk to the patient about the medication. If it was a really quick thing, easy thing, then maybe it's an 𝗧001. But if it's more extensive and you talk to them more about the side effects, talk to them about compliance and etc., maybe you might bill 𝗧007. And billing case number 5, a 31-year-old female comes in for a pregnancy test which proves positive. She's 6 weeks of gestational age. You interview and address all of her antenatal risks. You educate her regarding the latest maternal testing options, and you order her antenatal blood work. You start her antenatal forms, and you measure her BP and weight. She then books for her full prenatal exam at 9 weeks. So pause the video here, look up what you would think the answer would be and write it down, and the answer is D. And the reason why is because she hasn't done her major prenatal yet. That's going to be coming up soon. So that's why we build a P004 here. You bill a P005 for filling in that antenatal form. And then the G005 is when your nurse or you did the pregnancy test for her in clinic. Okay, so case number 6. So you provide counseling to a 25-year-old female with depression over the phone. What do you bill? Write down the answer, and the answer is D. So remember, even though we talked about K013, this is more so for like general counseling. For mental health specific counseling, you might want to consider K005. And the reason why in this particular case is because K005, instead of being paid at 85%, it's paid at 95% of the amount. So gives you a little bit more to do counseling over the phone. Billing case number 7. What do you bill for a video visit with a rostered child with sore throat and fever that you bring into clinic for a throat swab the same day? So pause the video, write down your answer, and the answer is D. And so the reason why is, remember, if you saw that patient in person the same day, then you can only bill for the in-person visit. The phone visit or video visit no longer gets processed or goes through, right? So then in this particular case, you would only get the billing code for seeing the sore throat. And if you did a rapid strep swab, then you get the billing code for that. If you saw that patient the next day, for example, then maybe C might be the right answer. So that brings me to the end of the PGY1 billing lecture. And in my second part of this lecture, we'll talk about premiums, modifiers, bonuses, talk about how to deal with rejected codes, uninsured and private billings, and we'll do even more practice scenarios for you to solidify your knowledge. For your homework, if you were ever confused a little bit about what's the difference between fee-for-service, family health org, family health group, all of those terms that I use, you can always reference this lecture for more detail. And if you plan to start off and practice in a FO, there is a lecture specifically just for that. So I'll link that as well below. And if you have any questions, feel free to leave it in the comments and reach out to me at Breaking Bad Dead on Instagram or on YouTube if you're a lecturer and wants to use my resources. And don't forget to like and subscribe to be notified of future lecture recordings. Thank you for listening.